So per what we have on the course outline, we should be done with musculoskeletal system today and then the neuro or the nervous system today. Yes, so that next week we move on to a different system. So if that is the case, I went through the status of the foot with us last week. And so those presenting on sports-related injuries and amputations are supposed to present. And then I would have to come in with head injuries and cranial surgeries, and then the group presenting on spinal surgeries was also coming. Or spinal, I think the tumors were for reading assignment, right? So yes, so what will happen is that group 3 will present, group 4 will present, and then I'll end with my presentation for head injuries and cranial surgeries. So the day is quite packed for surgery and surgical nursing too today. Group 3, are you ready? Should I stop sharing, or you can see my course outline as I have projected or I have shared? So you know that definitely I can't come in and present without group 3 presenting and then group 4 presenting. Next week, let's see what we have here. Okay, so next week will be solely for me. No group will be presenting. I'll come in with ulcers and burns. It's quite a lot. So I think I would have to exhaust the whole of the hours. And so maybe the following week as well, I have to begin the lecture, or begin the genitourinary system. I have to at least begin it before a group comes in to present. And so I also have to come in, and I think urolithiasis, urethral strictures, and hydronephrosis, within an hour I can finish with that. And so the next group on the line, group 5, please get ready for next 2 weeks. Please get ready. Group 6, BPH, hypospadias, you also should get ready. I'm sure next 2 weeks, yes, I don't know, but get ready. It's 5 and 6. Get ready. All right, so group 3, group 4, we are presenting today, and then I would come in, and so the time is a bit limited. Are you ready? Stopping sharing the course outline. And also that reminds me, I wanted us to have a full class before telling you this, but of course, in a part of the world, even if you tell just one person, everybody hears. I don't joke with my surgical nursing and my scores. I'm compiling my scores for your other group. This who just completed the semester with me. And it's not good. It's not good. And I'm not the type who also do let my people go. I don't do that. If you fail, you fail. You rewrite. If you rewrite and you fail again. So if you think you are here, you want to do just let my people go and then write and that's all. No. If you get 39, I'll give you 39. You won't say, oh, so only one. No, it's not only one. It's a lot. And I think the first day I didn't talk about our questions. For me, I do almost
Ma'am,
all types
please,
of
your line
questions.
is breaking. Please.
Maybe it's from your end. For me, I do all type of questions. assertion and reasoning, priority sequencing, starter, best options, filling, and then written. So don't take it as a joke. And you see, this part, surgical nursing, medical nursing, you see, there are some key things that key subjects that we don't just have to play with them. Even if you are not practicing within your unit, you may go outside, somebody may even meet you and ask you something. And you found yourself wanting. So there are certain subjects you don't just have to play with it. And we being practical or the practicing nurses should even give us that opportunity to have a grasp on some of these subjects. So please, just want to tell you, I don't do let my people go. Last semester, I think they are about well, I don't need to give the statistics, but I didn't like my results. Notwithstanding, that's not the reason why I would have to add dash 10 marks or 15 or whatever to everybody's scores or 20 20. I don't know how we do it. But for me, if you ask my regular students, they'll tell you, if you fail, you fail. You will write. When they are writing said what research for surgical nurses, as if they are writing a fresh end of semester exam. A lot of students will be in the class writing. So please, when you are discussing, take it seriously. And then afterwards, go and then reread. I think that I have said that my notes are quite scanty and I did it purposely for a reason. So that you would have that opportunity to reread or read wide other articles, other books. And on my course, I have also was bolding some books that you can, and you find it online. So easy to find. And our brilliance are that as nurses, we don't go away with that. Get it and read. Now, TikToks, YouTube, Instagram, there are a lot of videos on health, on conditions, where you can just sometimes short videos, 10 minutes, 5 minutes, 3 minutes. You watch about 4 or 5 different types of videos on that same condition, and you get a grasp on that. You get a bit of understanding on that, so that at least when some questions come, you remember that, oh, they said that, and so I can apply my techniques and be able to answer them. And I don't do what is in my questions, right? It is really practical, really practical. So it means that right after every meeting, we would have to. I know most of you have group studies or group whatever, WhatsApp discussions. Do that. Do that. It will help you. Other than that, a lot of you are ready for reset. Please. I'm sorry. Anyway, group one. Well, the last day I'll talk about how I've set my questions for. I'm still ongoing in the process of setting it, so I'll discuss how I do my questioning. And forget about past questions for me. Trust me, forget about that. Thank you. Please, group 3, your hands should be up so that I can take my roll call. Yes, so kindly start.
Hello. Good morning. Hello.
Yes, we can hear you. Kindly go on.
For a minute. Okay. Please, we are group 3 and we are presenting on sports-related injuries and amputations. Okay, so we are starting with amputations. Please, the next slide. Um, okay, so we are saying that amputation is the removal of a limb or a body part due to trauma, disease, or surgery. And it has a major physical and psychosocial consequences. So it's where you can see that the body part of someone is being removed due to certain situations. Please, the next slide. So if you when you see the picture in there, you can attest the fact that a part of the body is being taken off. And we are saying that the common causes for this amputation is complications from diabetes. That is the most indication. Then we are saying that peripheral artery or vascular disease, where there is occlusion within the legs. And as a matter of fact, and as a matter of fact, hello, networking.
Bye.
My dear, continue. We can clearly hear you, right?
Okay. Then also we are saying we have life-threatening infections, and there are other causes, malignancy or tumors, severe traumatic injuries, non-healing ulcers, gangrene, and severe trauma. So all these are causes for um, um, amputations. Then we are saying that we have clinical manifestation. The first one is pain, and we have what we call the phantom limb pain. Is where the patient after the amputation he still feels that there's pain in there. The other one is edema, that is swelling from the place that has been amputated. We have wound changes, we have bleeding and redness around the wound, then limited mobility and emotional stress. Look at the fact that your limb has been cut off. Definitely it's going to give you an emotional stress. Then we go to the types of amputation. We are saying that we have the levels. So we have the upper and the lower limb amputations. Then we say we have the extent to, we have the major, and we have the minor. We are saying that the major is the one above the wrist and the ankle, and the minor is basically the one distal to the wrist and the ankle. So when the minor is maybe when your fingers or toes are being there were removed. Then for the causes we have talked about, we said we have the traumatic, the surgical, and the congenital. So all the ones that we said, be it the malignancy, be it the severe infections, be it complication from diarrhea, these are all classified based on the three. Then we are saying that surgical technique, we have the open and the closed way of doing it. So we are for the open one, we are saying that it is left open initially, and the closed one, the stump is closed primarily. For the timing, we are saying that we have the primary and the secondary. After the amputation, when the patient is being exposed to whatever happens, we are saying that the amputation is done immediately after the injury. That is the primary one. And for the secondary, we are it is saying it is it takes quite a while before you can do it. For the pre-operative assessment, before a patient is being amputated, we have to go in for some assessment. We have to do the physical examination, the laboratory investigations, and psychosocial assessment and the patient education. Please, the next slide. So for our pre-op nursing care, we say we do the pain management. You talk to the patient as to the pain that he's supposed to be like expect, post that, then emotional support that you're supposed to give, because you know that the patient definitely after the amputation, you go through some kind of emotional trauma. Then informed consent preparation. You need to allow the patient to then sign. You, the nurse, supervise, and the patient will sign the informed consent. Skin care, then nutritional support. Please, the next slide. Again, vital signs monitoring, wound care, infection prevention, fluid balance, positioning and ambulation, pain management. That is the mirror therapy in the phantom pain. We are saying that all these are done basically after the surgery, especially with the position and ambulation, just to prevent edema. And the pain management, that is basically we use the non-pharmacological, where we use what we call a mirror therapy. The mirror therapy is basically you placing a mirror in front of the patient, and the patient. And to that, okay, please continue. So stamp care, after the patient after the surgery is being done, we are saying that you do an inspection of the stamp, the place that we did the amputation, the one that is remaining, that place, we call it the stamp. You do an inspection of it to see if there is any changes, if there is any swelling and that stuff. So you do an inspection, then hygiene of it, then shaping and bandaging. In a situation whereby you apply the bandage, you have to do it in a way so that contractures doesn't set in. Then this bandaging and the shaping also helps in edema control, and we also do the stamp care to help in prevention of the skin breakdown. If the skin is breaking, definitely would introduce other microorganisms which will cause complications. So we are saying that the complications after this amputation is the hemorrhage, surgical site infections, contractures basically from these bandages, and we are deep vein thrombosis, phantom limb pain syndrome. So that pain that the patient is feeling, it will become, it will be there. The patient will be consistently be feeling it. We have delayed healing, psychological distress, and osteomyelitis, as we've learned previously. Rehabilitation. We are saying that you do physiotherapy and mobility training. Since the patient is having a part of the body removed, you have to rehabilitate the patient, teach him how to move, because it's not easy. You that you are working with your 2 legs, at times it's even quite difficult for you to even work. How much more the patient who is having part of the body removed? So you need to educate or teach the patient with respect to movement. Then occupational therapy, then prosthetic fitting and education. There are instances where the patient is being given a prosthesis to wear, and as a matter of fact, you need to educate the patient as to how he needs to go about with this prosthesis and how to work on it. Then we have the community reintegration. You know that a patient who has gone and undergone amputation, we are saying that the patient is basically will be having psychological traumas and that stuff. So we, the community, at times we do sabotage them, or we do give them that kind of tag that they have amputated you, so you are not part of us. So as the nurse, you have to reintegrate these patients into the community, in a sense that they become part of us. To the fact that the fact that they have been amputated doesn't mean that they should be sabotaged, or they should be okay. So that's it. And we are saying that psychosocial support and counseling. So you support the patient and the family basically on everything that is happening. Anxiety strategies. Okay, so we move on. Okay, this was supposed to be in. So before you do the surgeries, these are the diagnostic investigations that you're supposed to do. You do the complete blood count, then you do the blood glucose and hemoglycated glucose. Basically, these are done in the situations of the patient having diabetes. You do renal function test, coagulation profile, you do X-ray, Doppler ultrasound, ECG or echocardiography. Then you do the CT scan and MRI. All these will help us ascertain where or what to do with the patient to the extent of damage that would initiate this amputation. Okay, so education, we are saying that you educate the patient on the stamp care. That is the first thing. You educate the patient on the stamp, how to care for the stamp. That is the first thing. Then again, you educate the patient on how to use the prostate, because the patient will be using the prostate for quite a while. Then exercises as to how the patient will be able to move about. Then follow-up visit and complications awareness. How the patient will be able to be recognize complications attached to this surgery. So you just have to educate the patient basically on all of this. Prevention. So we are saying that how do you prevent patient from maybe going like how do you prevent the patient basically from being amputated? This is in a situation whereby you can do something to help the patient. So you have to control the patient's diabetes, diabetes control. So in a situation whereby the patient is having his or her diabetes unregulated or uncontrolled, definitely it can lead to us amputating the patient. Foot care. And so when you do a foot care, definitely will help you in preventing that. Smoking cessation, vascular disease management, as in the case of the peripheral artery or the peripheral vascular disease, and injury prevention. When you prevent injuries, definitely there wouldn't be a need for us to amputate you. Okay. Sports related injuries. So we are saying that the sports related injuries, we have strain and sprains.
Hello, I'll take over from him. Hello, I'll take over from him.
Continue, my dear. Continue.
All right. So our next presentation is sports-related injuries, and then we're giving strains and sprains to present on. All right, let's continue. So sports injury is like any injury that one gets during sporting activities. And we say that like sports injury is any bodily damage sustained during participation in competitive or non-competitive athletic activity. And then sports injuries can affect bones or what soft tissue. We have types of what sports injuries. We have acute injuries and then we have chronic injuries. And then acute injuries are sudden injury or traumatic impact that can cause bone to crack, muscle tear, or ligament damage or tear. An example, we have a sprain. Oh, hello.
We can hear you, please.
Hello, please, can you hear me?
Yeah, we are
Yes.
with you.
So,
We are with
an
you.
examples of
We can hear you.
all right, examples of acute injuries. We have the sprain, strain, contusion, and then fractures. So this one is less just like during an exercise or sporting activities. Let's say you have a sudden injury or traumatic impact on any of your bone or your muscles. So that is what we say acute. It is a sudden. So it occurs suddenly. An example is what we have: the sprain, strain, contusion, and then the fracture. So we have the chronic injuries too. That one occurs repeatedly over a period of time. And then we say that chronic injuries caused by repetitive trauma. It may be result of a training error, too much physical activity with less duration. An example is heel injuries, knee injury. That is what seen pain in marathon runner. So we have some common sport injuries. We have the sprain and strain. We have knee injury. We have shin splint, fracture, dislocation, tennis elbow, muscle cramps, and then back pain. But we have so many, let me say, examples, but we are going to limit our presentation on strain and sprain. So now let's look at what a strain is. So a strain is like an injury to a muscle or a tendon caused by what? Overstretching or tearing. So if like a strain, we know something called tendon, and tendon is a fibrous tissue what? A strain. So we have some common sites that you can have this strain in, and we have hamstring. And the hamstring is like the lower part of your what? Your thigh. And then like we can have an examples of the muscles that are located there. We have biceps, or the back, the lower part of your back. We have muscles there that are what? That help the spine, or that what interconnect with the spine. So you can also have a strain at the what? The lower part of your back. You can have the calf, and the calf is the what? The back part of your lower leg, between the what? The knee and the ankle. And then we can have an examples of muscles that are found there. We can have the soleus, we can have the gastrocnemius muscles that are found in the what? The calf. So and even the shoulder too. There are also muscles that are what? That help the shoulder to what? The shoulder. So all these sites are very common that you can get a strain on it during a sporting activity. So now let's look at sprain. Sprain is an injury to a ligament that is caused by stretching or tearing. And we know ligament is a fibrous tissue that connects a bone to a bone. So when you have a ligament, the fibrous tissue that is connecting a bone to a bone, being what? Overstretched or being torn during a sporting activity, we call it a sprain. And remember, the spellings is it's very similar. The one with the ST is what is it? The tendon that is connecting what? A muscle to a bone. But the one starting with SP is what? Ligament. And the ligament, we said, is a fibrous tissue that connects a bone to a bone. Now let's look at the common site that we can have a sprain. We have the ankle, the wrist, and the knee and the thumb. Let's continue, sister. So now let's look at the difference between a sprain and a strain. In sprain, we say that it is what? A ligament injury. That's a fibrous tissue that connects a bone to a bone. And in strain, it's what? A muscle, tearing of a muscle, or overstretching of a muscle, or a tendon. A tendon that is a fibrous tissue that connects muscle to a what? A bone. So sprains usually affect joints. Sprain affect what? We have what? Pain, we have swelling, we have bruising, we have loss of what? Ability to move a joint. Because we know that sprain connect what? A ligament connect a bone to a bone, and definitely it occurs in the joints. So once you have a sprain, there will be an inability for you to move the joint. Now let's look at signs of strain. We have pain, we have muscle spasm. That's what? Excessive contraction of the muscles that causes severe pains. We have muscle weakness, we have swelling, and we have what? Inflammation, and then loss of what? Muscle function as a result of the pain. Let's continue. So now let's look at the causes. So we have force, we have sudden twisting of the muscles or the joint, we have sports injuries, we have heavy lifting. Now let's look at risk factors. Poor conditioning, like let's say that you don't position yourself, twisting your body in that kind of manner. It can lead to what? Strain or strain. We have fatigue, and then during sporting activities. Let's say if one get hamstring, there's a possibility that it can reoccur again. So now let's look at classification of what? Sprain and strains. Next slide, sir. So we have grade 1, grade 2, and grade 3. So grade 1, that is what? Mild stretching. Like let's say you have a sporting activity that you have like just a mild stretching of your tendon or your ligament. It's very mild. So that one is what? Grade 1. And grade 2 is partial tear. Let's say you have an excessive sporting activity that you have like a small tear of your ligament or your tendon. Or let's say a whole tear of what? A tendon or what? Hello?
Hi.
Bro, go on, we can hear.
Yes, next slide. All right, now let's look at the diagnostic investigations. Like we have the history, and the history is like an example of the conditions we are doing on is hamstring. So hamstring, once you get it as a footballer, there is a possibility that it can recur again. So now physical examination too. Like let's say the person have a sprain or a tendon, like you can do physical examination to determine the extent. We have X-ray, ultrasound, MRI when necessary. Let's continue. So let's look at the immediate management. We have summarized it as what? Rise. And the rise, we have rest, complete rest. Once the person is having a sprain or strain, so the person can rest completely for the pain to come down. You can also have ice, and the ice is like, there's you can put ice on the this cold substance on the part to bring down the pain. Compression to, like, let's also use bandaging to to like bandage it very well, like to mobilize it very well, so that it will be able to prevent further injuries or further pain. So now elevation too. When you have a sprain and strain, they say that there can be an edema, so you can elevate it to be able to reduce the level of edema. Next slide. So now let's look at the medical treatment. Medical treatment, sprain and strain, they have, when you get it, there's a lot of pain. So you need analgesics to bring down the pain. So if there's also an inflammatory processes too, definitely once you have sprain and strain, they can be inflammatory processes taking place. So you have to give NSAID to be able to bring the inflammation down. Immobilization too, once you have sprain and strain, like if you move the leg or the hand where you get it from, it causes further pain. So you have to immobilize it to prevent movement. So let's look at physiotherapy exercise to prevent stiffness too. Also improve range of motion, restore joint to normal flexibility and strength. Let's continue. So now let's look at the prevention. We have warm up, we have stretching, we have proper footwear, strengthening exercise, avoid as strong. So these are, I guess, some I could do in order not to get the sprain and the strain. Now let's look at complications. We have a chronic pain. Definitely, when you have a sprain and strain, like there's a lot of pain. So we have joint instability, because we know that sprain is is affecting joint. That is a ligament from bone to bone. So definitely, once you have a sprain, there's an instability of the joint. We have recurrent injuries too, and then reduce mobility because of the severity of the pain. Let's continue. Please, next slide. So now we have a key messages. We have sprain affect ligaments, strain affect muscles and tendons. So we have the management that we've categorized it as RISE. That is rest, ice, and compression, and then elevation. So prevention is essential. So they are telling us that maybe you can actually prevent these sprain and strains. So we have prompt assessment and treatment, reduce complications. Let's say someone is having a sprain and strain. So if you manage it early, it can prevent complications. So we have education and preventive measures are important. So this one, maybe there are some activities or things that you can do to prevent this sprain and strain. So now I think that's all our presentation. Thank you.
Yes, that's great. Thank you so much. You have really presented within time. That's great. Do you have any questions for them? I'm sure it wouldn't be anything so much that you can't go and read about. Or is there any clarification? Right, so kindly put your hands down. Your slides, you are more than 58 members or so. And then when you began, I think I had only 41 group members. And I don't know, later, some joined. Group 3, as well, 4, spinal surgeries. Please come in.
Hello, good morning.
Yeah, good morning.
Madam, please, this is group 4. We are presenting on spinal surgeries.
All right, so go ahead. Thank you.
Okay. Please kindly share the slides here.
Okay, please, I'm trying to share. A minute.
Okay. So with our introduction, group 1 mentioned about some spinal conditions like scoliosis, kyphosis, lordosis, and some other spinal conditions. And we group 4, we are here as perioperative nurses and orthopedic surgeons to actually look at how those procedures are being done, their pre-op, intra-op, and post-op management. So before then, we have to look at how or the components of the spine, talking about the cervical vertebrae, the thoracic vertebrae, and the lumbar vertebrae, including the sacrum and the coccyx. And if you talk about the vertebrae, they are made up of the individual bones that comprises of the spine. They are there to support the body's weight, protect the spinal cord, and also allow movement of the spine. A disc is also a soft cushion that is actually found in those vertebrae. They are the ones there to act as shock absorbers, also prevent the bones from rubbing directly against each other like a synovial joint, and also allows flexibility of the spine. And when we talk about the vertebra, so I'm saying this so that when I get to the conditions and I mention a disc, I mention vertebrae, I mention a lamina, you'll be able to identify where these things are located. So lamina is part of a vertebra. When we talk about the lamina, they are the flat bony plate that actually forms the back of the vertebral arc. They form part of the vertebral canal. They also protect the spine, and they provide attachment to muscles and ligaments. So these are some of the things we are going to mention. So if you mention discectomy, we mention laminectomy, we mention foraminectomy, you should be able to identify where these things are located. All right, so please, I'm waiting for the slide.
Please, are you seeing it?
Yes, please, I can see.
Okay.
So when we say spinal surgeries, we are talking about surgeries that are being done on the spine. There are procedures that are being done on the spine, the vertebral column.
Hold on. How do you enlarge the slides? It's quite on a phone mode.
Okay. Please, is this okay?
Yes, please, I can see that.
No, it's not okay.
Please, the one sharing, do you have WPS on your phone?
I'm using WPS, but I don't know why.
So you press the
Please
play,
click on play.
the play. Click on the play aspect there,
Oh,
down
okay.
there. Yeah, and then turn your screen.
Please, is it okay now?
Yes.
Hello.
Okay.
All right. So any operation that is being done on the spine. So when we look at the picture there, you see the cervical, the thoracic, the lumbar vertebrae, the sacrum, and the coccyx. That makes up the spine. So we are aimed at decompressing those neural structures there. When we are to stabilize the spine, we do those spinal surgeries. When we are to correct deformities, we do those spinal surgeries. Sometimes people have chronic spinal pain in cases of spinal compressions or those nerve root compressions. We do those surgeries, and sometimes as they are performed as conservative treatments. If physiotherapy and those medical treatment fails, that is when we do spinal surgeries for them. Please kindly move on to the next slide. So the incidence, mostly we do lumbar spine surgeries often. So when we take the total percentage of the spinal surgeries that we do, we have about 60 to 70% forming those surgeries done on the lumbar vertebrae. Then we also have the discectomy and the laminectomy also being performed. So when we look at other rates, we look at those surgeries done on the cervical vertebrae, accounting to 20 to 25%. And there are some also done on the thoracic vertebrae that is also accounting to less than 5%. So these are less common due to the rib cage stability, because we know that the thoracic vertebrae are connected to the 12 ribs. Please, next slide. So classifications of spinal surgeries. Based on the surgeries we are going to talk about here, we're going to talk about the ones that are being done to decompress either the disc or the vertebrae. So they are classified into three: the decompression procedures, the ones that are going to stabilize or fuse the vertebrae, and the ones that are going to correct deformities. So example like the discectomy, the laminectomy, the spinal fusion, the foraminotomy, the corpectomy, and the kyphoplasty or the vertebroplasty. So I've already explained these anatomical things, so we are just going to go into the conditions and their management. All right, so when we talk about a discectomy, so discectomy means we are going to remove a disc. As I already said, that the discs are found in between those vertebrae. So any surgical procedure in which part or all the intervertebral disc is being removed, especially when it is pressing on the spinal nerve or the spinal cord. So we have some indications where we do the discectomy. We remove the whole disc. So especially when the discs are herniated, what we call the herniated disc, when the patient has persistent back pain or neck pain caused by nerve compression, when the patient has sciatica, that is a pain radiating to the down leg, when there are numbness and tingling sensation or weakness due to those nerve compressions, and when those nerve compressions has actually caused loss of function and neurological deficit, that is when we do the spinal the discectomy. We remove the disc. So the benefits are to relieve pain. The benefits are also to improve mobility, and also it helps the patient to actually manage his or her own daily lives. So the types that we have three types of the procedure, the discectomy. We have three types of the procedure. We have the micro discectomy. So with the micro discectomy, a small incision is being done to remove the disc. We have the open one through a larger incision and endoscopic discectomy. So we know that as the world is advanced, we've actually had endoscopic procedures whereby we use a smaller or a tube or an endoscopy to just go and remove those affected discs. So the procedure is being done by an orthopedic surgeon. So actually they make a smaller incision or a larger incision depending on the type the surgeon is going to choose. So the surgeon makes an incision, withdraws those muscles apart, get the disc affected and remove the disc and do the repair. So that is how the procedure is being done. So as I already mentioned of the advantages, they relieve nerve pain quickly, improve numbness and weakness, and it also helps the patient to manage his or her own daily activities. So there are other complications, because in as much as we are going to go into the body tissues, there is going to be infection, introducing pathogens into the body. There are going to be bleeding because those vertebrae are actually being high. They are highly vascularized. There are going to be nerve injuries because the spinal that we are going to work on. When we look at the peripheral nervous system, we talked about the nerves being found on those vertebrae. Then sometimes there will be CSF leakage, there will be reoccurrence of the herniated disc. Actually, when we do these things, the patient doesn't stay in the hospital for a very long time. They come back and work within 24 to 48 hours, and they can easily resume activities within 2 to 6 weeks. And we tell the patient to avoid lifting heavy objects, engaging in strenuous activities, and the patient will actually do a good, what we call resume normal activities, maybe heavy lifting and all those things after 12 weeks. So that is discectomy. So we are going to talk little about laminectomy, to how the procedures are being done and their indications. So please, okay. So removal of a lamina is laminectomy. So I've spoken about lamina. So any surgical procedure in which all or part of the lamina is being removed to relieve pain on a spinal cord is called laminectomy. So laminectomy may be performed for spinal stenosis when there is narrowing of the spinal canal, when there is herniated disc that is causing nerve compressions, when there are spinal tumors, spinal injuries, and degenerative spinal conditions. That is when we do um, laminectomy for them. And the benefits are to reduce pressure on the nerves, improved neurological functions. So that is laminectomy. So how the procedure is being done is we just give anesthesia to the patient, any form of anesthesia based on the surgeon's assessment. The incision is made on the vertebra. The surgeon removes part of the vertebra or, the lamina, part of the lamina, or if all the laminas are affected, it is being removed, and the pressure that is being exerted on the spinal cord is being relieved. Then the incision is closed. So as I've already spoken about, the patient is going to have complications such as infection, bleeding, nerve injuries, then CSF leakage, and sometimes spinal instabilities. So these benefit the patient through pain reliever, reducing numbness and tingling sensations. It's also going to improve mobility and walking ability, and it's also going to decrease the nerve compression symptoms. So post-operatively, how we are going to manage our patient. So we have to monitor the patient's neurological status, the movement, the sensation, the strength. We also have to assess the patient regularly, check the surgical wound for either bleeding or infection. Then we encourage early ambulation as prescribed. Then we have to also teach proper body ergonomics. Yesterday we spoke about ergonomics, how the patient has to sit, if the patient has to bend, if the patient has to twist. These are proper body mechanism that we have to teach the patient. Please, next slide. All right, so we are going to talk about spinal fusion as our third condition that we do. So spinal fusion, the surgery explains itself. So we are going to fuse the spine together. So permanent joining of two or more vertebrae. So surgical procedure that permanently joins two or more vertebrae so that they heal into a single solid bone. So when you do a spinal fusion and the bone doesn't heal to a single solid bone, then means you have not gotten your therapeutic effect. So the bones has to heal into a single solid bone. So this is done to reduce movement between those bones. So if the bones are miscommunicating, we have to fuse them together. So then we have two examples of spinal surgery. That is the anterior cervical and discectomy and fusion, and posterior lumbar interbody fusion. So the purpose are to stabilize the spine, provide spinal stability. So in the cases where we have spinal instabilities, we do this procedure for them. Then eliminate abnormal bowel movement. So I will explain why it eliminates abnormal bowel movement. So in cases of degenerative disc diseases, spondylolisthesis, when the vertebrae are slipped, that is what we call the spondylolisthesis. Then scoliosis, as group 1 mentioned, when there are spinal fractures, when there are tumors of the spine and spinal stenosis, we do spinal fusion for them. So getting to the end of my presentation, we have a condition we actually talk about. When we talk about, we look at the reason why those with spinal, when we do spinal fusion, it eliminates abnormal bowel movements or abnormal movements. So I'll speak about that. So the procedure is being done under anesthesia. The surgeon places a bone graft between the affected vertebrae. So the metal rod, screws, plates, or cages may be used to hold those vertebrae that are miscommunicated into position. Then over time, the bone grows together and fuse into one bone. So the advantages, as I've already spoken about, is they stabilize the spine, they reduces pain caused by abnormal movement, that is the miscommunication of those vertebrae. Then they correct spinal deformities and they protect nerves from further compression. So the patient is at risk of infection, bleeding, nerve injuries, failure of fusion, that is the the non-union. Madam spoke about it, I think 2 weeks ago. And the adjacent segment disease. Sometimes those nearby vertebrae are being stressed. So after fusion, they are not able to align. That is what we call the adjacent segment disease. So post-operative nursing care, we will have to monitor neurological status as in the patient movement, the patient sensation, the patient strength. We assess pain and administer prescribed analgesics because the patients will actually be in pain. Then we have to check the surgical site for bleeding or infections. We have to encourage ambulation as ordered. Then there's one thing that we do: we log roll the patient or remove the patient as one unit. So when we are lifting the patient, group A doesn't lift the head, group B doesn't lift the spine, and group C doesn't lift the legs. So in our theater, we count 1, 2, 3, then we lift the body as one movement. Then you have to teach the patient proper body ergonomics because mostly poor posture attribute to those spinal conditions. So avoid bending, lifting, and twisting during recovery. Actually, they don't actually stay in the hospital for very long. So if we do the surgeries for them, they can stay at the hospital for around 2 to 5 days. They resume light activities after a few weeks, and the complete fusion of the spine can take about 6 to 12 months. Then the spine can heal. It can form one body movement. Yeah. Please, let's go to the next slide. All right, so the ones that I've mentioned are the classical surgeries or the major surgeries that we do for patients with spinal conditions. We also have other ones such as the foraminotomy, the corpectomy, the vertebroplasty that we do for the patient. So foraminotomy, when we say foraminotomy, it means we are doing an incision into the foramen. So any surgical procedure performed to enlarge the intervertebral foramen, that is the opening through which the nerves are being innervated. That is the foramen. So when we are doing foraminotomy, then it means we are doing widening of the neural foramen, either to relieve pressure on the spinal nerve or to create stability. And foraminectomy means we are removing the foramen. So removal of a bone or tissue which is causing compression or narrowing of the foramen, we just do into. So when we check the space, and we actually need to take the foramen to create a space for the spinal innervations, we go inside, then we do foraminectomy. But when we can increase the space of the foramen, we do foraminotomy. So in cases of foraminal stenosis, when there is narrowing of the foramen, we do foraminotomy. Then when there are herniated discs, that is compressing on the nerve root, we can do foraminectomy. Then bone space, that is osteophyte that has been found in the foramen, we can just go inside the foramen, do foraminotomy and remove those osteophytes out. Then cases where the patient have severe pains and numbness and weakness in the arms, we can just go into the foramen either to do nectomy or to actually look at what is happening there, then remove whatever is found in the foramen. So, as I've already mentioned, the surgeon just makes an incision over the affected, go into the spine. If it is small portions of the bone or ligament or disc materials are being.
Mr. Emmanuel, I'm
the
sure you are taking note of those disturbing my class, right?
Yes, madam, I am taking it.
Thank you very much. I'm grateful.
You're welcome, sister.
So small portions of the bone, ligaments, or disc material that is narrowing the foramen is being removed and the incision is being closed. So we do these procedures to relieve nerve pain. We reduce numbness and tingling sensations. We do this procedure to improve muscle strength if the nerve is actually being compressed, then to preserve most spinal movement. So these things cut across all those spinal conditions. They are post-operative management, there are complications, that is infection, bleeding, the nerve injury because we are going to work on the spine, severe self leakage because of what we are going to do on the spine, and we can also have reoccurrence of the nerve compression. So post-operatively, we have to monitor the neurological status, the motor and the sensory functions of the patient, assess patient's pain level regularly. We observe the wound for signs of infections and bleeding. We encourage ambulation because we cannot let the patient lie in bed for long. And we have to encourage ambulation to prevent atelectasis, DVTs, and the others. Then we teach patient proper body economics. We teach the patient to avoid excessive bending, twisting, and lifting of heavy objects during recovery. So that is about the foraminotomy. So the corpectomy is a surgical procedure in which all or part of the vertebral body is being removed, or those adjacent intervertebral discs are being removed. So that is corpectomy. So removal of the vertebral body, especially common in tumors and severe trauma. That is when we do corpectomy. So a corpectomy may be performed during severe spinal cord compression, when there are cervical myelopathies, when there are spinal tumors, when there are vertebral fractures, when there are severe degenerative spine diseases, when there is infection to the vertebra, which is being unresponsive to severe antibiotic therapy. We can just go and do corpectomy for them. So how the procedure is being done, we approach the spine, the surgeon approach the spine. Mostly it is done from the front of the neck of the during cervical cases. So when the cervical vertebrae are being involved, we do them from the front of the neck. Then the diseased vertebra or the body and the adjacent disc are being removed. So we do hello, madam.
Is there a
Hello.
problem? Yes.
Yeah, please, my network went off.
Okay. So resume.
All right. So I'll finish soon. I'll finish soon.
All right.
So corpectomy to decompress the spinal cord effectively, relieve pain, weakness, and numbness, and restore spinal alignment and create stability. So the risk and the complications we have already mentioned about in our previous discussion. Then the last procedure we look at is vertebroplasty. So vertebroplasty, we know that plasty means reconstruction. Vertebra is the vertebra. So reconstructive surgery of the vertebra is vertebroplasty. So what we do is here there is something we call a bone cement. A bone cement. So it's like our normal cement. So when we have conditions like osteoporotic vertebral compression fractures, so there are fractures of the vertebra, we just go inside, inject directly bone cement into the fractured vertebra. Then the cement will just fuse together to provide stability to the vertebra. So it's like you have a crack in your wall, then you put cement inside. When the cement dries, it seals the crack. So the purpose of vertebroplasty: relieve severe back pain caused by vertebral compression fractures, stabilize collapsed vertebra, improves mobility and function, and prevent worsening spinal deformity in some cases. So that is vertebroplasty. So the indications are, I think I mentioned the osteoporotic vertebral compression fractures, especially in the elderly people. They are predisposed to fractures. So we do these procedures for them. Then when there are pathological fractures, either due to metastatic cancer, multiple myeloma, or vertebral hemangioma, we do vertebroplasties for them. Then when there are painful vertebral fractures lasting weeks, of which conservative treatment has failed, we can go and do vertebroplasty for them. We inject cement inside. The cement will harden to cause stability. So I think I've already mentioned, I've even talked about how the procedure is being done. The patient is positioned under an anesthesia. As a bone cement is injected into the vertebra, then the cement hardens quickly and stabilizes the spine. So that is vertebroplasty. So please, let's go to the last part of our slides. So okay, kindly go back for me. Kindly go back for me, please. Please kindly go back. The slide before the diagnostic investigation. Yeah, okay. So all right. So there is a condition called the Corda equina syndrome. That is the last thing that we are going to do, the Corda equina syndrome. So this is a medical emergency. This syndrome is a medical emergency because this syndrome is caused by compression of what we call the Corda equina nerves. Those nerves are at the end of the lower end of the spinal cord. So when you look at the spinal cord, the lower end, it elevates around the L1 and the L2, the lumbar vertebrae, the L1 and the L2. So that is where the spinal cord, we assume they end. So this end of the spinal cord, when they cause compression, that is what we call the Corda equina syndrome. So it is a medical emergency because these nerves there controls movement. That is why I said that these conditions will actually promote good movement of the body. Yeah, so that is the anatomy of the Corda equina nerves there. So when there are compression of those nerves there, that is what we call the Corda equina syndrome. And it is being, I think it is around the L1 and the L2. So the common causes of this, the Corda equina syndrome, when there are massive lumbar disc herniation, when there are spinal traumas, when there are spinal tumors, when there are infections of the spine, when the spine is being stenosed, or as a surgical complication or post-operative complication of the various spinal procedures we've already talked about, when there are hematomas that has been formed around the L1 and the L2, causing compression of those nerve roots, you can have the Corda equina syndrome. So it is a medical emergency, and as at the end, you have something you call the saddle anesthesia. So when you are being given a saddle block, where these saddle block are being affected, the bowel movement, the inner thighs, the lower limbs, and the others, that is what we call the saddle anesthesia. So the patient will be there, and the patient or the person cannot lift the leg. The person can feel pains in the thigh. The patient can have constipation, less bowel movement. That is what we call the sudden anesthesia. So urine retention or urine incontinence, bowel dysfunction, and the bilateral leg weakness. Leg weakness. So that is what we call the CODA equina syndrome. And there's one thing, it also affects we the men. It also affects we the men. It can cause sexual weakness. The CODA equina syndrome can cause sexual weakness. So if you are there and you have sexual weakness and you think you can use those aphrodisiacs, sometimes they are compression of the L1 and the L2. So you can do other investigative to look at what is actually causing the lower the low sexual libidos on the low sexual performances. Yeah. So the importance of the surgery that we are going to do for the CODA equina syndrome is to relieve compression on the L1 and the L2. That is the reason why we do this procedure for them. Yeah. Please, let's go to the next slide. So for all the cases that we have done, when we want to do diagnostic investigation, magnetic resonance imaging, we do scan, do our X-rays, and based on the histories, we'll be able to know what is exactly like. So for the CODA equina syndrome, we'll do pharmacological treatments like the paracetamols, the NSAIDs, the pregabalin, the gabapentin, corticosteroids, especially when there is severe inflammation that is causing the nerve compression. Then we do muscle relaxant. If the muscles are so compressed on the nerves, we do muscle relaxants for them. And the non-pharmacological treatment, we do physiotherapy, we do exercises, we do tractions and bracings for those patients. Please, next slide. Yeah, so interventional procedures that we do epidural steroid injections. So when the patient is not complying to oral steroids, we can do epidural steroid injections for them. Then we do selective nerve root blockers so that these ones will not compress on the nerves. Then the goals are to reduce inflammation, relieve pain, and to delay or avoid surgery. So when we don't want to do surgeries for them, or when we want to delay surgeries for a specific number of time, we do these interventional procedures for them. Kindly go to the next slide. Yeah, so the surgical management, I think we've already spoken about most of them. We do a somatosensory evoked potential, that is what we call the SSEP, the motor evoked potential, that is the MEP. So the approach is we just go to where the nerve compressions are, then we leave the compression on the left. That is how the surgical management is. And we've also talked about the post-operative management too. The patient should resume activities, but not as soon as possible. Proper body economics. The patients will continue taking their steroids and pain medications. Yeah, so that is the surgical management. Kindly go to the next slide. I think we are almost done. Yeah, so the preoperative management, we do assessment, the baseline neurological evaluations, we monitor the motor strain, sensory status, reflexes, then patient education, our log rolling technique that I already mentioned. We do deep breathing exercises. I think I've spoken about it. Then we use our incentive spirometries to prevent atelectasis and the others. Then we encourage early ambulation. Can you go to the next slide? Yeah, so these are pre-operative things. These are things that we all actually do. The nursing responsibilities, patients on MPO, verify informed consent, ensure that blood are available. We do skin preparation. Then, so these are basically what we actually do for the patient. We already know this. Kindly go to the next slide. So post-operative management, I think I've already mentioned about it. The monitoring of the neurological status, the sensations, the motor, the reflexes. You observe when there are new weaknesses, you have to report. So it means that you have actually caused another nerve compressions at the other end. Then when there are loss of sensations or increasing pain, it means that we actually haven't gotten the therapeutic effect of the surgery. So you have to quickly monitor to the surgeon. All right. So these are our post-operative management that we've already talked about. Yeah. So these are the post-operative management. So kindly go to the last slide. Kindly go to the last slide. All right. So there is a summary there. So summary of these spinal surgeries, when there are severe nerve root compressions, when there are spinal fractures, we do the when there are disc compressions, that is when we do the discectomy, the foraminotomies, the corpectomies, the kyphoplasties, the vertebroplasties for them. So this is basically the spinal surgeries. Thank you, madam.
All right, thank you very much. Any questions for them?
Good morning, madam and everyone. I want to add something with the spinal surgeries. Most of the conditions and where the site of the injury have occurred, most of them they lose or there's loss of sensation and motor movement to that side. Let's take it that the injury occurred at a C6 or is T3. So below that level, there's usual loss of sensory or motor movement below the site of injury. So that's what I want to add. And most of those cases too, we medical management, they also put them on anticoagulant because they are not moving and they are not able to do exercises. The blood circulation is somehow impaired, so they have to put them on anticoagulant, which will also improve venous blood return to the heart. Thank you.
All right, thank you. Any other? All right.
Hello, good morning, madam.
Your hand should be down, eh?
Okay.
All members, your hand should be down. Please, you be the last person so that I can also move on with my presentation.
Okay, madam. Please, I would like to ask.
That can be a question. May class.
Please, I would like to ask that the the equidal syndrome, is it sudden or it develops gradually? When you got there, my network was not stable, so I couldn't hear. Thank you.
No, group members.
So I said it is very sudden. So in a case when there are ischemia to those nerve roots, they can cause compression. When there is an inflammation to those nerve roots, they can cause compression. And when there is severe vertebral compressions too. So it is very sudden. It's an emergency. Yeah, it doesn't develop over time.
All right. Let's move on now. Thank you. If you have any other questions, maybe we can still go and do a bit of reading to get more understanding. So as projected, we are going to discuss a head injury as well, and we'll be done with the two systems. We'll move on to the next system next week. So your group, you don't do, is it first aid and disaster management or something for the regular students, right? Or is there something you do in relation to emergency care, emergency management for top-ups? Because I'll say you have maybe met it somewhere before. Anyway, so head injuries. It's quite a broad thing when you talk about head injuries. You talk about injury to the scalp, to the skull, to the brain, right? Dora, Dora, is there a problem?
I'm part of the group for Brazil is my hand.
Hey, madam.
No,
So when we talk about head injury, it's more of the skull or brain. It's quite broad. Of course, the scalp and skull injury sometimes is quite a minor, right? Unless we have the severe aspect as well. And then in severity, then it means that it's affected also the brain. And so we will have to talk about traumatic brain injury. That is the severest or the most serious form of head injury. In terms of its causes, the most common causes of this traumatic brain injury are the RTS, motor vehicle crashes, the violence, and then falls. Then, in terms of incidents, high risk groups are the males and then children. I'm sure that if you want to think outside the box, you realize you would have to understand why males are really affected based on the causes that we have here. And then also children and children below 5 years, also based on the causes we have here. And then the elderly to extremes of age, right? Above 75 or over 75, they are also have increased risk of these injuries. And so we should know that more males are affected than the females. Scalp injuries. So I said earlier on that scalp injuries are quite classified as minor injuries, minor head injuries. So these trauma the other result from abrasions, contusions. Yes, that reminds me. Can you read on concussion? This is a part of it, and it's quite on the minor side, but I have a read on concussion. So we have the abrasion, the contusion, the laceration, and of course, hematoma that builds up beneath the layers of the tissues of the scalp. Hematoma. When we talk about large scalp avulsions, then we are talking about emergencies, especially due to severe bleeding. It's a life-threatening emergency and it has to be attended to. Scalp fractures. So we know of a fracture. So a break in the continuity of the scalp. And then we know that as a result of what? A forceful trauma. It occurs with or without brain injury. And so when there's scalp fractures, there may be brain injury or not. There may be damage to the brain or not. We have its classification or types: the linear, the comminuted, the depressed, and then the basilar. Mostly the basilar fractures also has a lot of complications. We can have an open fracture, just like fractures, so it can be open. That indicates that the scalp, there has been a laceration or a tear in the dura. So dura tone, it may be open. There has been a tear or laceration in the dura. Maybe bullets, gunshots, whatever injury can happen that way. Or we can also have a closed, in which we have the dura being intact. You can have that closed one as well. When we have these closed ones or the linear, the depressed, it can be if only there hasn't been any damage to the brain, of course. If there's no traumatic brain injury, it can be managed conservatively, and then patients may be observed for a while before patients may be discharged. But then if there is trauma to the brain, that is when there will be issues. Or if there is open fractures, that is where there will be issues after assessment. We have CSF leak, we have battle cerebral raccoons. These are all clinical manifestations, signs and symptoms. Apart from the general persistent pain, severe headache, nausea and vomiting, convulsions, seizures, there may be brief level of consciousness as well, or even, yes, general level of consciousness will be distorted. Apart from all these things also, patients would have bleeding, of course. So there'll be hemorrhage from the nose, the ears, the pharynx, even blood appearing also at the conjunctiva as well. And so mostly we would have leak from the nose, leak from the ears. There'll be CSF leak as well as blood leak. And so when you want to find out really what the discharge is, and then that is where you're going to see what we call the halo sign. We will use is there a gauze or maybe a cotton to take the discharge. And then within the discharge, you see a ring-like, a yellowish ring-like thing within there, or on the gauze or on the cotton. That is the halo sign in CSF leak. So based on that discharge that we would have, this will be the sign that may be seen. Again, also, there will be ecchymosis over the mastoid area, the periorbital ecchymosis, that is called the battle sign. Battle sign. And then we would also have bruising around the eyes. That is the raccoon's eye, raccoon sign, raccoon eyes, raccoon sign, sorry, raccoon sign. All right, so these are the key symptoms of basilar fractures. With this, if in terms of earth management as well, if patient is, we have to maybe decongest the gastric, or if you want to maybe feed or anything, this patient, because there has been bleeding through the nose, the pharynx, the ears, and all that, we don't do nasogastric tubing, but we rather do orogastric tubing for them. So that is one thing, just because of the leaking and all that, we don't want to cause more complications for these patients. As part of our assessment, we want to do physical examination for these patients. We want to evaluate their neurological state. So Glasgow Coma scale, mostly for these patients, this is what we use to evaluate their neural status. We want to do CT scan for them, or MRI, better cerebral angiography for these patients, and then know how best to manage them. Generally, we have an overview of their management after we've discussed the brain injuries. Okay, brain injuries. What is it? What is it? So when there is any fracture in the skull, as I said, it's quite minor unless there has really been an effect to the brain. If it is even minor injury, it can cause significant brain damage to the blood flow to the brain. And when there is decreased tissue perfusion to the brain doesn't have enough, it's not so sensitive in storing oxygen and then glucose. It's sort of an uninterrupted blood supply or nutrients flowing here and there. It shouldn't be interrupted. And so, because the cerebral cells would need this uninterrupted blood supply or blood flow, and they will need these nutrients and all that. If there has been an interruption, irreversible brain damage and cell death may occur if there's that blood supply interruption within just a few minutes. And so when we do assessments, and then, or when we have patients, or just on physical assessment, we realize that there has been brain involvement, it is really something that we really have to attend to and not just waste time. In terms of its brain injuries, we have types. We have the closed, that's the blunt, and then we have the open penetrating. And so when you talk about the closed or the blunt brain injuries, this is sort of an acceleration or deceleration injuries, where the head will collide with an object, anything, a fall or whatever, and then the brain tissue becomes damaged. But then there is no opening through the skull or the dura. So there's a bit of brain shake. Yes. And then we have this open or penetrating, so open brain injury, when, of course, the objects penetrate through the skull, enters through the brain, and then there'll be damage to the soft tissues or the brain tissue within the skull. When this is so severe, of course, there'll be an opening, so the skull will be involved, the skull will be involved, and then the dura may be exposed. Ideally, the skull holds, of course, it holds the brain, and it holds the 100% content within the brain, and the brain and whatever makes up the skull. So the brain, the CSF, and then the blood. The brain tissues hold about 80%. The CSF and then the blood also holds 20%. The skull doesn't expand. That is one thing we all would know, that the skull doesn't expand. And so if there is any other thing, or should I say any foreign body or anything that shouldn't be part of what is already the content of the scalp, it will cause, it can't, the scalp can't expand, so it wouldn't be able to hold whatever new thing that will be part of the content when there's an injury. And so let's say a typical example, if there's a fall or an accident or whatever, and then there is bleeding, it means that there's going to be an extra content within the scalp, an extra content. Or maybe if there's, let's say, a swelling, it means that there has been an extra content. Or if there's a tumor, a growth, still an extra content. So what happens is that there would be a bit of compensation. So it is either the CSF will reduce its content, or the blood, there will be a reduce or reduction of blood flow to the brain. And so that few compensation, that few minutes compensation that happens will help the scalp still contain its 100% value. But then how long will it be able to do that compensation? So what happens is that if there is reduction of this blood or this blood flow, then it means that there will be a decrease in what? Tissue perfusion within the brain. And that can also cause what? Brain damage. Or better still, there will be also a reduction of the CSF. And so gradually with time, there will be an increase in intracranial pressure. With time, there will be an increase in intracranial pressure. So generally, when the brain suffers any traumatic injury, there will be what? A bleeding, there will be swelling. And that will increase what? The intracranial volume. So the scalp or the cranium, as we said, that it is so rigid that it doesn't really, it doesn't expand at all. Now, there wouldn't be room for any extra content. And so there will be what? That buildup of what? Intracranial what? Pressure. So the pressure on the blood vessels So the pressure within that on the blood vessels within the brain will cause what? Blood flow to slow down. And if it does that, there'll be what? Decreased cerebral tissue perfusion, which will cause what? This ischemia and all that. And then as intracranial pressure increases, what happens? There may be brain herniation and then cell death. That can occur. Okay. Intracranial hemorrhage. What really is intracranial hemorrhage? So hematoma that builds up what? Within the skull. So it may be epidural, it can be subdural, we can have what? Intracerebral. So we can have above the dura, we can have the below the dura, and then within the brain. And so we are going to talk about the epidural, the subdural, and I think the intracerebral. So the common causes will be what? The trauma, hypertension, aneurysm rupture. So it means that when there is rupture in maybe the arteries of the brain, then it can also cause that. Or better still, if patients take these anticoagulants, it may cause what? Bleeding disorders. And then AVM, so arteriovenous malformations. I think you've done that earlier on in Surgery 1. Any other abnormal blood vessel connections, right? Yes. And then tumors, brain tumors, that can also cause secondary bleeding. And all these things can increase the content of the brain or the content of the cranium or the skull, right? Epidural hematoma. Epidural hematoma. So right after a head injury, blood can collect between the skull and the dura. And that is epidural, bleeding between the skull and the dura. So maybe a skull fracture can cause that, and that can cause what? A rupture or maybe a laceration of the meningeal artery. So epidural is more of what? An artery involvement. Epidural is more of an artery involvement, a meningeal artery rupture. And so when there's rupture of or a hemorrhage from this artery, this will cause what? Rapid pressure on the brain. There has been a bleeding, severe one. And you know that if it's in relation to arteries, it's a gush of blood, right? Yes. But that's more of what happens. In terms of its features, patients may have what? A momentary or very brief loss of consciousness. And then there is what we call the lucid interval. In a way, patients may have what we call it an apparent a brief recovery. Patient may regain consciousness in a way, and then later they deteriorate. That's the lucid interval. You can go and read more on that as well. Patients, when there's epidural hematoma, they lose consciousness, and then they regain their consciousness, and then later they gradually deteriorate. Okay. And so there's what? After that lucid interval, there's what? Rapid deterioration of what? Consciousness. There's dilated, fixed pupils, paralysis of the extremities, hand paralysis. And then patients will have what? May have skull fractures as well. Then we have subdural hematoma. Subdural hematoma, we have it in acute stage, the subacute stage, and then the chronic stage. For subdural hematoma, generally, it is not sudden, as with the epidural. It is not sudden. Generally, for subdural hematoma, it's like there has been a fall or maybe a hit. Sometimes we don't even take that serious. And then after some time, patients start exhibiting signs of neurovascular or neurological compromise. Then we have to suspect what subdural hematoma. So we have the acute stage that is within 48 hours of injury. That usually complicates what maybe severe head injuries or that. At the time, patient's unconscious from that time of accident, and then gradually deterioration sets in. That is for the acute stage. And we have the subacute stage between 2 to 14 days after injury. And so patients may have head injury, and then it fails to improve as expected. Then patient may start developing signs and symptoms of any cerebral compression or any neurological compromise. And then we have the chronic, weeks or even months, and it's more commonly in the elderly. And so, as I generally talked about the subdural hematoma, so patient may have a fall for even, patient may not even remember that, oh, there was this fall some time ago. No, until there are symptoms. So sometimes the fall or the hit or whatever will be a bit trivial. So patients may forget. Yes, so gradually there will be that kind of symptom. For subdural hematoma, and then of course for the chronic stage, when patients maybe have some tumors in the brain and then there's some injury, that one is it's not so common. Or maybe the cause that we talked about, a rupture of any aneurysm or all that. Mostly it's not that common like the epidural hematoma. Then we have the infantile type. So the early stage of life, the 2 years of life, it may be caused by maybe birth trauma, where history also has been denied that, oh, this thing happened, because as I said earlier on, there would be a bit of forgetfulness from maybe whoever is the caregiver. And so maybe proper assessments and then scans are done for us to know that indeed it is an infantile subdural hematoma. So there are symptoms: headache, we would have nausea and vomiting, we would have altered level of consciousness. There's a bit of fluctuating level of consciousness, right? There's mental changes. Still, we would have hemiparesis also here. And then we have papilloedema as part of the symptoms. I think here I'll let you come in. What do you think are some of the assessments to be done for these patients? What are some of the assessments to be done for these patients? Or we should talk about it. We should discuss the nursing management. Yes, her CT scan. How can anticoagulant cause intracranial hemorrhage? Who will help us? How can anticoagulant causes intracranial hemorrhage? Who can help us before we talk about our diagnostics? So how can anticoagulants help intracranial hemorrhage? Cause rather. Yes, my dear Samuel, yes.
Morning, sister.
Good morning.
Since the anticoagulant is blood thinner, it thins the blood to make the blood very lighter. So when there is a slight injury that causes the veins to rupture, it causes a lot of bleeding. So that bleeding, once the blood is thinner, it comes profusely. That's what I think it causes intracranial.
Thank you. Thank you. Any other? Any other?
Sure. Sure. Headache and vomiting.
How can so I think more of what Sammy said, I thought maybe somebody would want to add on more. Definitely, as he said, if anticoagulants, we know it's a blood thinner, right? Yes. So now if there's any rupture or anything, any injury to even the small vessels or even the small blood vessels, then the anticoagulants will make it what? Very hard for clotting to take place. And so there'll be increased bleeding. And then we've said that the little extra content will cause what? ICP, right? Yes, so it's just about that. All right. So assessment, I've seen a lot, and that's very great. Yes. So we do history taking, we do neuro assessment, assess ICPs, dizziness, skull X-ray, GCS, very, very important. observe any CSF leak, history, MRI, CT scan. That's great. So we can move on. I remember last semester I was saying, oh, go and read on GCS because I didn't talk about, I think I talked briefly about it and they took it as a joke. And then thankfully they met it in their exam as a written question. So now I also told you to go and read on GCS, but definitely I can't repeat my questions. So, but kindly read, you can't do head injuries or brain injuries without knowing the GCS. I'm sure most of us have forgotten how to even assess patients with the GCS, right? So it's very, very important. So as you all said, and then I think a few ones are found here. A few ones are found here. So history and physical examination, neuro assessment, we want to do imaging, we have a lot. We have x-rays. Someone said, yes, plain x-rays is really part, right? So x-rays, plain x-rays, we have the MRIs, CT scan. I think I also told you to read more of the differences. How would you, what's the differences in MRIs and the CT scans, right? So still go and find out that. And then we have other angiographies, carotid, cerebral angiographies, they're all there we need to do. And then we have exploratory bare holes. We'll talk about bare holes very soon in the cranial surgeries. So these are all parts of the assessment you're supposed to do for the patient. And then we can't never go away with what glaucoma scale. What are they? What are the parameters? Glaucoma scale, what are the parameters? Yes, you observe for confusion because of neuro. So do all the neuro assessments, right? What are the parameters for glaucoma scale?
Hello.
Yes,
Hello, madam.
yes,
So the GCS, the parameters, we have verbal, we have eye opening, and we have motor.
very good. So eye-opening, verbal, and then motor, right? Yes. And what are the scores? The overall scores. Overall scores.
So
So eye, verbal, and then the motor responses. What are the overall score? For each. Anyone? For each. Generally, yes,
ma
15 for each.
madam, I think the eye opening, the overall score for eye opening is 4, and the verbal, the overall score is 5,
Very
and the
good.
motor, the overall score is 6.
Six. So yes, that's great. So 4, 5, 6, right? So if you forget anything, you know that we know you start from 1, 2, 3, then you go to 4, 5, 6. So 4, 5, 6. So EVM 4, 5, 6, right? Yes. So at least we have summarized it. Go and find out each parameter for the eye. What each parameter stands for. So from 4, 3, 2, 1, and then 0. Then 5, 4, 3, 2, 1, 0, and then the motor 6, 5, 4, 3, 2, 1. Please find out. And find out which score, which score is the highest, which score is the lowest, and how would you interpret it as well, right? Okay. So as part of the management, what do we do for these patients? Of course, for generally we don't really say what 0, 1, 2, 3, but least is 1. We can't use it. That means that patient is off, right? So yes, just that if it's nil, it's nil. Yes. So what are the nursing management? But please find out. We should know. We should be able to know how to use a glaucoma scale when a patient is unconscious and then patient is in front of you to assess. Definitely, you have to use that GCS to assess the patient. So if people are watching you and you are there, Mama nurse, oh, Papa doctor, where are you come? At least that's a few things you can do for them to know that, hey, Charlie, you're also there. Oh. All right, so nursing management. What do you do for these patients? Okay, so Mr. Chumesi has given us something for the eye here. So you have the no response, respond to pain, and then to speech. I think you've mixed it up. Or so no response 1, that's a nil, and then respond to pain 2, yes, and then to speech, yes, 3, and then spontaneous, yes, 4. What are the rest? What are the rest? Nursing management, please. Anyone?
Madam, good morning.
Yes, Andy, good morning.
Madam, I think with this, we'll try to maintain fluid and electrolyte balance. And
Great.
and another one I can remember is if the patient is comatose, intubating is necessary. So you ensure a sterile environment for that. And also protect airway. That's what I
Okay.
can remember.
That's great. Thank you. Very, very
Thank
great. Thank you. Any other? Any other, please? Of course, we can't do away with our ABCs and Ds and the rest, right? We can't do away with them. Yes. So apart from all these assessments, what else do we have to do? He talked about what fluid is what did he even say? Fluid and electrolyte balance, hydration. Yes, it's also one of the key things we are supposed to do for the patient. Yes, provide bed rest and then a noise-free environment. Yes, these patients are quite irritable, Yes, at the extremes. And so they also need a serene environment. Yes, Ophelia.
Madam, good morning.
Good morning.
Sometimes with these patients, most of them are unconscious and they are bedridden. So normally we send them 2 to 3 hours, and then we keep a pressure sore chart. And then if unfortunately patient gets there, so we dress it, and then you assist them with their daily living activities. You help bath them in bed, you do mouth care, and then sometimes if the patient has NG2 too, you plan a diet with the patient involving the dietitian, and they'll get you the diet plan and you follow. Thank you.
That's great. That's great. I think we said also that in terms of NG2, we should be specific. Some type of injuries would need oral, right, and not nasal as well. That's great. Thank you. Thank you very much. So generally, yes, I've seen some few ones also in the chat. Yes, your intake and output, your oxygenation, airway, breathing. Yes. So we will have to do, yes, of course, definitely when patient comes in our care, we do our ABCs, we do our assessments, we will take history, level of consciousness, and then know whether even it is about maybe is it alcohol, is it epilepsy, whatever condition that has caused that, right? Is it RTA, is it hypertension, diabetes, whatever, or is it even drug injection? You have to check all these things, do a proper history of these patients, and yes. And then we'll do a physical examination as well. We want to do a physical examination, so we'll do our general checks, our GCS, we'll do that. We want to assess for CSF leak. We want to do that, so we'll check the ear, the nose bleeds, and then check whether there is any CSF leak. We want to do that. So we want to, of course, do our vital signs, right? Very, very necessary. So all those neurological monitoring will be there. And then fluid and electrolyte balance. We want to monitor fluid and electrolyte balance. We want to support skin integrity. Sister rightly talked about that. In terms of mobility, if you want to do range of motion exercise, their family coping. We want to really talk to the family very well for them to understand how the treatment regimen is like and how they can also have that kind of emotional support. As part of the medication that's supposed to be given, we're supposed to give antibiotics. So yes, ideally, if there is an open fracture, then you would want to give that, or if there's a tear or any laceration. Other than that, we have to hold on with antibiotics for the start. Yes. But if there's an open fracture or any other tear or anything, then we have to give her antibiotics, anticonvulsant. And then yes, to decrease the intracranial pressure, we want to give osmotic diuretics. Mostly we give them mannitol for them, or we administer mannitol, yes, as an osmotic diuretic that helps draws that water or that fluid from the brain tissues. So it helps to give that bit of reduction for them. Is there any other thing you want to add on? If there's any other thing, please you can add on, or better so when you go and do your discussions, you try to talk more about them. Yes, of course, wound dressings. We want to talk about wound dressing of course, there are certain things that are key things that if we are doing an assessment and we know that we have to monitor, even if you don't find it in our slides here. Yes, my dear Mildred.
Sister, please, good morning.
Good morning.
Please, I read that in the case of head injury, you don't give monitor unless the patient has increase intracranial pressure. Please, I want you to clarify that for me.
Yeah, I think basically that's what I said. We're giving that to reduce intracranial pressure. So it's more about that. Is that okay? Or is there any other thing someone wants to suggest or add on? It is more of when there is increased intracranial pressure. But
Sister,
you see,
please,
there are head injuries. Yes.
usually, immediately the patient comes with head injury, you see that people will be giving monitor.
Yeah, but you see, mostly when there are head injuries, if you understand a bit of the pathophysiology that I said, I talked about, there's no way patient will have head injury where there wouldn't be an increase in intracranial pressure. Well, we said that the content within the cranium or the scalp there can't be any addition. And so when there's injury, it means there may be swelling, there may be bleeding, or any other thing. Or better, even if there is it's not a violence thing or a traumatic thing, and even let's say it's just a brain a tumor, brain tumor or whatever, still there has been something that has been increased with the content of the scalp or the cranium. And so there will be increased intracranial pressure. And so it is part of the medications to be given to the patient. Okay. Let's see what we have here. Okay, so all about management. Is it advisable to give morphine in case of head injury? What do you think? Mr. Foster, what do you think? So in every head injury, yes. So it's rather DNS that we don't administer. You can go and read more about it. Let's just move on. So, please, my last person to ask question, I can just move on. We have 30 minutes more, even though we are almost done. Phenoria, yes.
Madam, please, good morning.
Good morning.
Yes, please. Madam, I want to comment on the monitoring in head
Yes,
injury.
yes, comment.
Most,
Yes,
most,
very nice.
most often with our settings, a lot of the time we don't have facilities that can do the head CT for us to rule out increased intracranial pressures and other corresponding head injuries. So they
Mm,
look at the signs and symptoms and then they will start management. And most often when they just see those signs and symptoms that what do we call it, implicate increased intracranial pressure, they continue with the setting of the monitor. What they usually do is they consider which of them to be first, either the 10% or the 20%.
okay,
So far as there is signs and symptoms of increased intracranial pressure, they go ahead to
okay,
give their monitor. Yes, please.
okay. That's great. That's great. Thank you very much. Very grateful. But I'm also interested in that question where the Foster asks whether morphine or any other opioids can be given to these patients. Please, if you don't answer that, please find out. I think my last semester as well, I think I met the same question. I met it. All right, so management, surgical management. We have bare hole, we have the craniotomy. We have bare hole, we have craniotomy. So when you talk about bare holes, small holes drilled to relieve pressure or drain blood, just about that. So we drill or there's a drilling. I won't say we drill because I don't drill. So there's a drilling of small holes within the skull, right? To relieve that pressure on the brain. That is also done typically to drain blood or any other fluid buildup. Any other fluid buildup. So bare hole is created to drain that fluid buildup. Ideally, the bare hole, yes, is created either at the side of where they do the fracture, the scalp injury, or better still, the people that's which whatever is quite dilated, that is where they do the bare hole. And so there's a perforator and then there's a bare. And whenever they are doing the bare hole, so of course the temporal bone is quite thin, and so care is really taken. Initially, now there's advancement in technology, so the side is seen through imaging to know this is the exact place we are going to locate to drain the fluid buildup or the blood or whatever. But ideally, maybe as one rightly said, that we don't have the necessary items within all facilities. And so mostly when they do the bare and then they don't find any hematoma or anything, then they have to do another drilling again. You don't find any hematoma, they want to do another drilling again. So ideally, 6 bears are supposed to be created for you to, or for the surgeon to now clear themselves, the team to clear themselves that no, there is no hematoma buildup. If, of course, there are no amenities or there are no resources to see that, oh, I can just use an image or a scan to see the exact site where we have the fluid buildup or the blood buildup. I don't know whether I get it clear. Can we move on to the hematoma? Mr. Arthur, the craniotomy, sorry. Mr. Arthur.
Yes, madam. Sister, please, I want to touch on the morphine and then
Yes, yes,
administration
sure.
of head
Very,
injury.
very necessary, yes.
In my facility, we were not really doing it because we sat down and we thought it was not very pressing of necessary because one, the signs and symptoms of morphine or side effect of morphine, one of them is respiratory depression.
Yes.
It causes respiratory distress. And then it also sometimes masks neurological changes. And then mostly to hypotension. So when the patient has head injury, you see that the patient is already having all these signs and symptoms already. So by administering morphine, it will rather go and then also depress the patient's system more, and then we are rather going to even kill the patient more than doing great, or more than letting the patient recover. So that's the reason why we don't. Thank you.
Thank you too. I think you've answered that. You have answered that. That's great. Mildred, do you want to add on?
No, madam, please, when we were talking about the intervention, we didn't talk about positioning of the patient. Usually we put the patient in a supine position, which is wrong. Because when you put the patient in a supine position, you say there is an increased intracranial pressure, you still worsen the case. But when you put the patient, you elevate the head of the patient to about 30 degrees, you
I didn't talk about that. Then that's a very great. Someone will say my bad, because this is not something I should escape at all. Positioning, yes. Thank you for that. Yes, continue.
yes. So you elevate the head of the patient in order to ensure venous drainage. Thank you.
Very, very necessary. Very, very necessary. You don't put patients supine. You have to elevate to at least 30 degrees. We can't just put patients supine. If we do that, we are going to still increase intracranial pressure. And that is a very bad thing for us to do. But I think some of these things are key things that if we are talking about it and then we miss it, we have to prompt us all so that we all have a bit of idea about it. I don't know whether it is part of after my surgical management, I would have to talk about it or not, but I don't know why I have to miss that. All right, thank you very much. So I said, as she said, yes, at least between 30 to 35 degrees, you have to elevate the patient's head to reduce ICP, right? Yes, and then to help promote venous drainage. It's very, very important, all right? Thank you very much. All right, so let's talk about craniotomy briefly, and then we end it. What really is craniotomy? So it's a surgical procedure that helps, or that um, um, we have to helps how should I even put it? It involves removing the temporal the skull temporarily, right? Remove the skull temporarily so that we can get into the brain. You can assess the brain, right? Yes, so a removal of the skull bone to assess the brain. So you want to do that to either treat any other conditions, whether tumor, we want to remove the tumor, whether aneurysm, we want to, if it's rupture, we want to tie the vessels together, whether hematoma, I want to drain it, hydrocephalus and all that. You want to just enter the brain to treat whatever is found in there, right? That is basically what craniotomy. What like how is it done, or what is done when you are doing craniotomy? So basically, we shave the scalp. We want to wash there, especially when there's fractures and other, wash there copiously, and with saline to remove all the debris and all that from the scalp, and then the fracture is exposed. So the scalp fragments will be taken away, or will be lifted, and then the area will be divided a little. And then if there's any defect, it can be repaired there and then. If the skull fragments it cannot be patched, then we have to take it away and then use maybe a bone graft or any artificial graft thing to secure the place, right? Yes. So if edema is present, then it means that when they have to take off the skull fragment, if they're pregnant, they have to hold on for a while for that reduction to take place. The defects will have to be repaired before they can now do any grafting for this patient. If there's any wound within, any penetrating wound, then all these foreign bodies are supposed to be removed, and then hemorrhage is controlled. before any other thing can be done for the patient. We would want to give antibiotics before even surgical intervention and then during. Of course, with these patients also, we have to give them blood. It has to be on standby. Blood has to be on standby. Blood components are supposed to be given for the patient. The nasopharynx, the pharynx, the ear, all should be kept clean during, before, after. Those areas should be kept clean. We want to cover the place, let's say if the ear, the nose, at least with a piece of cotton, we are supposed to put there loosely so that if there's any CSF leak, it's supposed to be collected in the gauze or the cotton or in the nose or the ear. We are supposed to put it there to drain that fluid, but it is put in there loosely. It's loosely. These patients mostly also want to prevent them from blowing their nose, straining, sneezing, coughing, and all that. We want to prevent them as well. We want to monitor patients, GCS, we want to monitor people responses. We want to perform neurological assessments. We want to do that. We want to assess the level of consciousness of course, just like we do for pre-ops vital signs, every 15 minutes for the first hour, 30 minutes, and blah, 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 till the patient becomes stable. How would we assess for raised intracranial pressure or increase in the cranial pressure? And so we want to assess for decreased level of consciousness, pupil changes, if there's headache, is it the headache getting worsening, or is there seizures, is there vomiting? We want to assess all that. There's what we call the Cushing's triad. Let's find out what really it entails and how to assess the hypertension, bradycardia, irregular breathing. Let's really read more on the Cushing's triad there. We can't also do a neuro assessment postoperatively without talking about the Cushing's triad. So let's find out. Increase BP, hypertension, bradycardia, irregular breathing. What take does it have for patients after cranial surgeries or patients basically with head injuries or traumatic brain injuries? Yes, Regina. Okay.
Hello,
So
madam.
yes.
Good morning. Please, I'm sorry. I was at a noisy place, so I had to adjust myself a little. Talking about the nursing management, I wanted about the hydration. I want to also add up that during brain injury, we don't give glucose-containing fluids because it will worsen the intracranial pressure. The brain cells will absorb more fluid, worsening the person's sensorium. Thank you. But I have a question too about the morphine. Our brother made us to understand, or he explained that morphine is not a good choice during brain injury because of the respiratory depression and others. But I wanted to ask, what about fentanyl, sufentanil, pethidine, or other opioids? Tramadol. Thank you.
All right, thank you. I think they all have the same class of drugs. They are all within the same class. So if they are all within the same class, then we are not supposed to give those medications. Those medications that will generally depress the respiratory status, depress the generally even cause the same symptoms that the patient is presenting. We're not supposed to give. I think there's even a point there where we say manage pain without excessive sedation. If we do that, then how would we really do get a better assessment of the patient and know how the patient is responding to treatment, right? Because it gives the same, should I even say side effect or therapeutic effect? Yes, it's in a way an adverse effect for the medication that we give. These are the adverse effects, and these effects are more of the symptoms that the patient will also present. And so if you want to really assess the patient's progress, it's going to be difficult, right? All right, so we want to maintain head elevation. I think here the position has come in here. Yes, we want to maintain head elevation at 30 degrees, between 30 and I think 35 in some books. And they want to monitor wound for infection or CSF leak. And so apart from the wound, so all those things, if it's the wound, we want to monitor for CSF leak, you still want to look out for the halo sign. If it's the nose and then the ear also, there's the drainage, you want to find the CSF leak. You still want to find out the halo sign. You can go and read more on the halo sign. And then pain management. So we do pain management without excessively sedating the patient. We want to assess patients' motor and sensory functions as well. And so all the GSS will come here, limb weakness, with the movement, response to stimuli, and all that. We want to do that. And then monitor fluid balance. We want to monitor fluid balance. So fluid electrolyte balance, we want to do this monitoring very well. And so intake and output, if patient is on any, if patient is less than diabetic as well, and they are on any of their medications also, they also has to be monitored. Their urine output are supposed to be monitored. We want to watch for any other syndromic effect of antidiuretic hormones also. We want to check for any common complication that affects what sodium and then fluid balance for these patients. It's very, very necessary. We want to check even the wound drain. We want to inspect the surgical side, the drain site of infection. We want to aseptically dress patient's wound and then check for any excessive bleeding. That is also very, very important. In terms of the positioning, apart from we doing head elevation within this 30 degrees level or 30 to 35 degrees level, we also want to avoid extreme flexion of the neck and then rotation, right? Everything that we can do to avoid to prevent intracranial pressure, we want to do that for the patient. And then we want to still monitor the patient's patency of the drain so that there wouldn't be buildup of fluid. If there is a buildup, and so whatever we are doing, it won't last or won't be effective, right? There should be that free flow of drain, and then always have to record our drainage and then do a proper intake and output. I think there is more, if you want to go and read more of the nursing management, also operatively, I think we can get more of that as well. So from here, you can go and read more, especially with, I think we didn't talk about psychological management, the cognitive and the emotional support. Please go and read more about that as well. Not for anything, for us to just be able to coach the family members very well and talk to them very well, especially also when patient is regaining consciousness. Complications. So these are the complications here. These are the complications here. Do you have any questions on the complications? Can we move on? I think it's quite clear. And then what to do to prevent generally head injuries, brain injuries, traumatic brain injuries, skull fractures, and all that. What do we do to prevent that? We have a lot. So these are a few ones also we have here. Do you have any questions? Do you have any questions?
Yes, madam.
Yes.
Now the complication, I didn't see brain death.
Yes. I think when we're even talking about the pathophysiology, in a way, we talk about, yes, brain death. But let's see, is there anything that... Okay. Yes, Pat. Brain death is Pat. Thank you. Okay, someone rightly said that
Madam,
head injuries are better managed with IV PMO. What is Acupam? What is Acupam? All right, yes. Is there anybody who wants to add on anything?
hello, madam.
Yes.
Good morning.
Good
Please,
morning.
it's a little clarification I want to get. You see,
Yes.
to avoid the intracranial pressure, we are
Mm.
avoiding any desperate fluid. So, okay, in
Mm-hmm.
case of a patient with hypoglycemia, are we maintaining that to avoid the um intracranial pressure? You are not giving, or we can give a bolus and still continue the management. Thank you.
Okay. So in case of any hypoglycemia, what do you do for these patients? In case of any hypoglycemia, what do you do for these patients? What do you do for this patient in case of any hypoglycemia? Anyone? Yes, Ebenezer.
Madam, good morning.
Yes, my
Uh,
dear. Good.
I remember this incident happened to me once when I was under a care of a patient, and with the surgeon, our scenario, we tackled the hypoglycemia first because that was an emergency, and then later he gave instruction how to deal with the intracranial pressure. But from there, we make a decision in the one that mostly will prevent such an incident again. So most patients are coming with will come with head injury or undergo craniotomy. Mostly what we do much is that we make sure that they come with NG tube and we monitor their FVS and IVS and we feed them. Mostly we make sure they come with NG tube and feeding is one of their most priority in order to avoid such an incident again. So that was what happened in my case.
Okay.
Thank you.
Okay. Thank you very much. You see, mostly in our practice. Yes, do you want to add on? Someone said hello. I think our time is even almost up. Yes. So in our practice, we mostly would have to want to prevent complications. We want to manage what is the most critical that may send patient to his or her death, right? So we want to tackle that before any other thing. And at least comparing ICP and then hypo, which one should be tackled first? And so we weigh all the benefits and the risk, and then we tackle that before we tackle the rest. All right, so we can read more about whatever we have discussed if you have any clarity, and we are good to go. Thank you very much for today. Let's meet next week.
Thank you very much, sister.
Thank you, sis.